We have a really interesting topic today to cover on cancer pain management and opioid use in humanitarian settings. I think we're going to learn a lot from our guest speakers, but I wanted to give an opportunity for people to introduce themselves if we haven't met you before, or if we have met you, reintroduce yourselves for those who it might be their first time here today. So does anybody want to go ahead, or I might just start going through the list and seeing who wants to say hi? I'm Sarah, for those of you who don't know me. Welcome. Grace, is that you?
Hello.
Hi, Grace. How are you?
Yeah, I'm Rose from Palliative Care Association of Rwanda.
Ah, okay. Very nice to meet you, Rose. Welcome.
Thank
Hi, everybody.
Grace,
I'm Erin. I'm a palliative care nurse living in Nairobi, originally from Canada. I'm happy to be here. Thanks, Sarah.
I'm sorry, our electricity just went off. Yeah, I've just had to turn to hotspot on my so I'm hotspotting from my phone.
Okay.
Yeah, Kenya, this is it.
Well, we're glad you're still with us. Anybody else would like to introduce themselves? Sylvester, are you there? Or Leah? Odwar?
Good afternoon, everyone. My name is Leah Odwar. I work for International Rescue Committee, Kakuma Refugee Camp, as a Community Health Program Officer. Thank you.
That's great. It's really nice to have you here today. What about Hassan Kadar? Are you there? Are you able to introduce yourself to the group?
Yes, salam. Yes, my name is Hassan Khadar. I'm Hargeisa, Somaliland. So I'm nursing trainer for Adna Aden University Hospital. So hello.
Yes, welcome.
Hello. It's okay. Okay, welcome. Thank you. You hear me?
Yes, we can hear you.
Okay, my name is Hassan Khadar. I'm Hargeisa, Somaliland. So I'm nursing trainer for Adna Aden University Hospital in Hargeisa, Somaliland.
Okay. Welcome. Thank you for joining.
Thank you.
Hi, Ali. Thank you for joining. Nice to see you.
Thank you, Erindas. I'm in attendance today to join the second session of Community Practice Project ECHO. Thank you.
Welcome. All right, I guess we can get going with our session. If you want to introduce yourself in the chat, please go ahead. It's nice for us to feel like we are building a community here. So it's nice to learn a little bit about everyone. And there is a bit of a time gap between when we meet. So it's nice to be refreshed on who everyone is, and so that we can all get to know one another. So welcome everyone. For those of you who are just arriving, my name is Sarah, and Erin is here today too. I'm going to help facilitate the course today. So I'm really, really excited about this topic. I'm sure we all know by now, but we are talking about cancer pain management and opioid use in humanitarian settings. So this is a really, really important topic. It's one where we can all stand to learn more. And I really hope that you have brought some questions with you today. We have, we're very lucky to have an expert with us today, Dr. Zipporah Ali. She is a leader here in Kenya in palliative care, and will have so much to offer in terms of information on this topic. So please, please, please ask your questions, share some of your experiences. I think the more we participate, the more we can learn. So I was honored to meet Dr. Zipporah Ali last week at the National Palliative Care Conference in Kisumu, and I am so excited to be able to introduce her today. After we have her talk, we'll open it up for a little bit of discussion, then we'll move to a case study brought to us by the MSF team in Sudan. So hopefully we're going to learn from that study and be able to share some knowledge with one another. And then Erin will close off the session with a little bit of information about going forward for December and then into the new year. So Karibu, welcome, and let's get started. Dr. Zipporah Ali, I'll let you take it away from here with the presentation, if your internet is allowing you to do that.
Good morning. I've just had a sound that my TV is just gone on, so that means the electricity is coming back, but the internet will take some time before it goes. It's on. Can you hear me? Can you hear me?
We can hear you. Yes.
Can I be heard? You can hear me, yeah.
Yes. And just a reminder,
So,
sorry to everyone, please.
You are breaking, so I was thinking maybe I'm also breaking. So let's hope the internet.
Oh yeah, no, we can hear you. But I was just going to quickly remind everyone to stay on mute during the presentation. And if you have any questions, please put them into the chat box or save them for afterwards, and we'll get to all of them. Thank you, Dr. Zipporah.
Okay. Thank you. I'll just open my say hello so that people see the face that's talking. Then I'll put off my video because I'm not sure about my internet. Ali, it's nice to see you here again after having seen you in Kisumu, and also Sarah and Erin. Sorry, let me close my video. Why is it not closing now? I think I've gone off again. Sorry. Am I still on? Yeah, okay. So I've been asked to talk on pain management in the use of opioids and pain management and use of opioids in humanitarian settings. I'll probably focus on pain management, as I think the case that will probably be presented to us, you'll be able to give us an overview of what it is like managing pain in humanitarian settings. I wouldn't know exactly what is available in wherever you're working, your settings that you're working in. This is just the slides that come with a course. And I think this is that this is a partnership with Palliative Care Association. I don't know if I'm still on or not, but I'll try to see if I can go through this with all the challenges I'm having in terms of internet. I'm hoping that by the end of this session, we'll be able to just understand what the definition of pain is in the most simple way, and maybe understand why we need to treat pain, and then understand a little bit about pain management as recommended by the WHO, the World Health Organization. And then, like I said, the case study will help us understand more about opioids in humanitarian settings. So This is just a slide to show the definition of what pain is. The International Association for the Study of Pain has a scientific definition for what pain is. It says that pain is an unpleasant sensory and emotional experience that is associated with or resembling that associated with actual or potential tissue damage. So we see that it's an unpleasant thing. It's also an emotional experience, and it also might be having some actual or potential tissue damage. But the definition that I actually find is very helpful.
I think we may have lost Dr. Zippy. Are you still there?
I can't hear her.
We'll give her a minute just to come back online. She said she was having some challenges with her Wi-Fi today.
Can I have a few other people introduce themselves? Sarah, there's Omar, Maria. Maybe they could just share where they're working.
Yeah, hi Omar. How are you doing? Can you share where you're working?
Hello, I'm Faria Ibrahim. I'm palliative care nurse working at Laikipia County, Nanyuki Hospital.
Okay, welcome Faria. Thank you for joining today.
Thank you.
Hi Omar, I see your video there. I think you might have to unmute yourself. If you're having any trouble with audio, please just feel free to participate in the chat.
Oh, this is too bad that Dr. Zippy's connection is not so good. Sarah, what could we do? I do actually have the case from the team in MSF. I think
Sudan.
because they were going second. Sorry,
Mhm.
yeah. Because they were going
So-
second. I haven't seen them join yet. I could speak
Yeah.
to the session.
Yeah. Do you have Dr. Zippy's slides?
She did upload them, so I could quickly download it and yeah.
But we could talk
Sarah-
about the case.
Yeah. Sarah, do you want to just give a quick update about the workshop? And I can put up a few things. Maybe you and Ali could give a quick update. Sorry, guys, our plan and schedule for today is not going exactly as we were hoping. But maybe we take 5 minutes now. I'll try and see if I can download the teaching from Dr. Zippy.
Okay, so I'll just share a little bit about the upcoming workshops. So we were going to talk about this at the end of the course. So I'm not sure if all of you have heard, but we are going to be creating 2 working groups. One that's going to be talking about morphine access and availability within humanitarian settings, specifically within and then the other working group, Dr. Zippy's back, will be about strengthening referral pathways. So we'll talk about that more at the end. Maybe we'll let Dr. Zippy take over the presentation.
Thank you. I'm sorry, I'm having challenges. It told me I'm locked out of a video call. I don't know what. It looks like I'm back in. Can you enable me to share, please? Says the host has disabled participant screening.
Hello, welcome back. Okay, yes. Are you able to share your slides?
No, I'm not able to share. I think I'll send them to Erin just in case also, because it looks like I'm not able to share them.
Sangamitra, can you?
I still can't share my slides, but I've sent them to Erin. I don't know if they'll get through. Anyway, as Erin maybe is able to manage them. Erin, have you received them? I'm so sorry.
Yeah, Sangamitra in Echo India, can you make me a co-host now or host? I think I got so knocked off.
Yeah, everybody's
Sarah,
knocked off.
Are you a co-host, Sarah?
Yes, I am.
I can, yeah, I can give you the, do you want me to give the host access, Erin?
Doesn't matter, either one.
Okay. Okay, I have given you the host access. Erin.
Great.
Have you received the slides, Erin?
Yes, yeah. Let me
Okay.
get them up.
Maybe just go to I think where I was talking about the definition of pain. I have to now rush. As Erin is looking at the slides, I can just maybe continue. I was talking about the definition of pain, and apart from the definition that maybe scientists like to use about tissue damage and the rest, there's a simpler definition that that we also encourage people to take into consideration, and that is that pain is what the patient says it is for them. Because sometimes we think pain has to be physical, has to be very obvious on the patient's face, but sometimes really what the patient is talking about when they're talking about the pain, and we look at that very briefly, is what we should believe. When the patient says, I have pain, then you should believe they actually have pain. So pain is actually a symptom, it's not a disease. And then also it's what the patient, we need to believe the patient is what the patient says it is for them. It could be affected by many different factors, biological, psychological, social factors. And sometimes we just think that unless somebody says I have pain, they don't have pain. So it might not always be verbal, it can also be non-verbal. So we need to be able to differentiate this and understand when the patient says pain. For us, our part is to believe that that patient has pain, especially for you who are working in those humanitarian settings. A patient's pain might even be beyond the physical pain because of the situation they find themselves in, being away from home and also not being able to access quality healthcare. Next slide, please, Erin. So I will not go into details of this. So pain can actually be either physical pain, where sometimes you have somebody will talk about having a physical pain and maybe demonstrate where the pain is, the type of pain they have. It can also be a social pain, because of loss of the role in the family, they have lost their income, and many things have changed in their day-to-day life. They're no longer who they were, family worries and all those things. Then it might work worries as well. It might also be spiritual. When people ask themselves, what have I done to deserve this illness? Have I done something wrong to my creator? Why am I having this illness? So it can also be emotional, so it might come with symptoms like anxiety, depression, and many others. So again, pain is not just physical. You have to think of it as being having many dimensions to it. Next slide, please. So we are supposed to be talking about pain in cancer mostly, but we do know that most of our cancer patients will have pain. Some studies say about 55%, others say 65%, others say 75%. But I took this from the WHO, the most recent WHO publication, which says 55% of patients undergoing treatment for cancer will experience some sort of pain. And then 66% of those who have metastatic or terminal cancer will have some sort of pain. So pain is very common in cancer patients. We need to be able to identify this pain and treat it. Some patients might not have pain at all. So also we need to be aware of that. Not every cancer patient will have pain. Some patients may have one pain, others might have more than one pain. So when you're assessing pain, we need to find out, do they have one pain? Do they have two pains? What type of pains they have, so that we can actually decide how we are going to treat this pain. The pain could be because of the cancer itself, maybe a visceral organ, a bone, or soft tissue infiltration, or it might actually be because of the surgery they have gone through. The wound can also be having, a lot of, can cause a lot of pain. Any additions can cause pain, and also it might be because of the radiotherapy or the chemotherapy they're receiving. Most patients on chemotherapy will complain of peripheral neuropathy, so we also need to be aware of that. They will complain of pain in the mouth because of the mucositis that they have in the mouth. So again, we need to look at, if you're treating cancer pain, what could be the cause of this pain, so that we can also focus on the cause of the pain. Next slide, please. So why should we manage pain? Sometimes people ask, why are you managing pain? Pain is a good symptom because it tells us, it gives us information about the illness, whether it's progressing or not. But I don't think any of us would like to have pain because it tells us how the disease is progressing. If you remember, you can recall maybe if you've ever had a toothache, how and especially the toothaches like to come at night, how you can't wait for the morning so that you can go and see a dentist, or when you start looking for medication. I know that at one time I even crushed, aspirin and put in my tooth because it was too painful. So again, pain is not something that we should let patients live with, because we think it's helping us understand if the disease is progressing or not. Pain should actually be managed so that patients can focus on other things, on their day-to-day life, on maybe even if they're being rehabilitated, if they're undergoing cancer treatment, if they're undergoing treatment for any other NCD. They should actually have their pain control so that they can focus on other issues, relationships, family, meaning of life, and even if they're still going to work, they can focus on their work. So we need to really focus on managing pain and not give any excuse for not managing pain, except the excuse of the fact that maybe you don't have access to the appropriate medications for managing pain. So next slide, please. I'm trying to rush because I've already lost like 10 minutes. Next slide. So when we're talking about pain, we need to understand about what types of pain you're talking about. And usually this is a topic by itself, which can take some time when you're talking about classification of pain. So I'm just going to kind of do an overview of it because of time. We talk about nociceptive pain, which is really pain when there's tissue damage. Additionally, this is can be very well controlled by analgesics. We can divide this into two types of pain. For example, somatic pain, like pain you might see in metastatic bone disease. Is patients will describe this pain as throbbing, aching, or stabbing. And then we might talk about a visceral pain, which may be pain in the internal organs, for example, in the liver capsule, if the liver is swollen or something like that, a colic pain. So we need to be able to differentiate, is it a nociceptive pain? That's the tissue damage related pain. And if it is it somatic or is it visceral? So again, these are things that would need time for us to be able to understand in detail what it is. Then we talk about the other pain we talk about is neuropathic pain. Usually neuropathic pain is done, most of us fail in terms of identifying it as a neuropathic pain and also treating it. Sometimes can be very tricky to treat a neuropathic pain, which comes actually because of nerve damage or nerve infiltration. Most patients will actually describe this as a burning pain or a shooting pain. They'll have different definitions, prescriptions, how they define this pain when it's neuropathic pain. So sometimes they'll even talk about numbness. So this could be central from the brain or spinal cord, or it could be peripheral. And like I said, peripheral nerve pains can be very common in patients who are receiving chemotherapy. Most doctors sometimes, or clinicians or nurses, have difficulty in controlling nerve pain because they have not made a good diagnosis, and also because they don't know which combination of drugs would actually do well in terms of treating nerve pain. So we can actually talk about pain also in terms of the duration. Is it a chronic pain? Is it an acute pain? We know acute pain will be there for a few weeks, days, or maybe 3 months, and then it goes away, or it might actually develop into a chronic pain. But we also know that chronic pain is pain that has been there for a long time. So we could talk about the origin of the pain and different things. But it's very important for us to understand what type of pain we're talking about after we do a good assessment of the pain, so that we can actually treat it appropriately. So The different mechanisms of pain are important because the pathophysiology of each pain is different. And again, this is a whole topic on its own, understanding the pathophysiology of pain. And presentation will also be different, and management is different. Next slide, please. Pain assessment is important. We should be able to identify what is the cause of pain. Some of the causes of pain might easily be reversible. We can treat them and manage the pain, and others might not be. It might not be easy to manage them. So we actually, when you're taking pain, we need to talk to the patient, even as we identify what pain they have, and we use tools to identify how much pain they have. We also need to do this regularly. Even if you start the patient on pain management, you need to maybe review them in the next 12 or 24 hours, or even more frequently, to see if you're managing the pain or not. So again, pain management involves the patient as well, so that they can tell us what levels of pain they're having, because they'll be able to describe the location of pain, what makes the pain less, or what makes it severe. We usually talk about the PQRST, which is P stands provocation, where what makes the pain worse or better. Q is quality. What kind of pain is it? Is it sharp, dull, burning, or an aching pain? R is the region or the radiation. Where is pain located, and where does it go? Does it go to other parts of the body? And S stands for severity, or the scale. How severe is the pain? And this is where the pain tools, pain measurement tools, become very useful. And then the timing. When did the pain start? Is it acute? Is it chronic? Has it been on for a long time? Is it constant, or does it come and go? So these are some of the things we need to remember when you're doing pain assessment, so that we can also, this can help us manage the pain as well. Next slide, please. So when we are performing a pain assessment, it's important for us to remember that there could be more than one pain. When you're asking the patient, you have pain, and they'll tell you, I have pain, maybe I have pain in this part of my body, that part of my body. And the description of the pain might be different. Maybe in one place it is stabbing, one place it is a dull pain. So we need to ask those questions. So we need to establish how many different pains there are. And then for each pain, maybe ask some of the questions that I actually had mentioned in the previous slide: the location, the nature of pain, how severe it is, and the impact of the pain on their quality of life. So some patients will say that I'm not able to eat, I'm not able to do anything, sleep, or even spend time with my family because of the pain. So this is just to identify that we need to be able to know where the pain is, the character of the pain, the timing, and what treatments they have received previously, if they have helped or if they have not helped, and then what makes the pain, less or worse. And just like I explained in the former slide, what the impact of the pain could be on the patient's quality of life and how severe the pain is. Next slide, please. So when you're measuring pain, if you go to the website that we're using for this echo session, I've uploaded a small book called Beating Pain. That book can give you more information about some of the things I'm talking about, because I'm rushing through them. But it can also, if you look at that little book, Beating Pain book, it's a pocket book, but I've given you the soft copy. You will see it has got some pain measurement tools that you can use. I've just put a few here. There are scales that have been validated that can be used for measuring pain. They're very simple, 0 to 10 scale. Some people might use a 0 to 5 scale. And then, of course, we talk about the FLAG scale, which looks at things like the face, the legs, and other parts of the body. So I'll talk about that a little bit in a while. So 0 to 10 is really a scale that you can ask the patient from 0 to 10, where is your pain, and 0 is when the patient says, I have no pain. And then if they have some mild pain, they might say, I've got pain, it's level 2 or level 3. As the pain continues, then you see that they will say, my pain is at 4, 5, 6, and then 7, 8, 9, or 10. This is to help us to understand how severe the pain is, and also how to manage the pain. Because at level 2, 3, we might just need to use mild analgesics like Brufen, diclofenac, Panadol, or aspirin, the one we usually use, the non-opioid analgesics. But as we go into moderate pain, then we might need to use the weak opioids. And as the pain becomes severe, then of course now we introduce the opioids for the pain management. Next slide, please. So this is the one that is usually used, the FLAC or FLSCC scale, face, legs, activity, cry, consolability scale, is really used for children who have been maybe 2 months to 7 years. who are not able to verbalize the pain they have, but it can also be used for others who are not able to talk about their pain. And in this particular tool, you actually look at the face of the patient. Is there an expression on their face? Is there an expression? Do they have agreements? You actually monitor the expression on the patient's face. If it's a child or an adult, then you also look at their legs. Are they in a normal position? Are they kicking their legs? Are they drawn up? Are they in a fetal position? So all these things are also very important. If a person is not able to explain their pain to us, we can actually observe the position of their body, the facial expressions, the legs, and what activities they might, are they moving or are they quiet? Sometimes somebody can be in so much pain that they don't want to move, because movement will cause a lot of pain. So you might find the patient is not moving, but they could be having also interesting, movements like rigid or jerking because they have pain. So if it's a child, are they crying, or are they, do they cry when they're asleep or when they're awake? And so those are some of the things we might look at. Are we able to, to talk this child to stop crying? Are they relaxed, or do they continue, crying even if we try to make them, not cry in many ways? So this is the measurement tool that we use mostly for children between the 2 months to 7 years, but also it can be useful for others who are not able to talk, to tell us about their pain. Next slide, please. So why do we want to do an evaluation of pain? Why are we talking about evaluating pain? Because we want to know what the etiology of that pain is, so that we can treat it better. We want to see if it can be corrected. If it's maybe because of, for example, an infection, can we treat that infection? If it's because of a fracture, can we correct that fracture? So we need to understand, is it a pain that we can actually correct by focusing on whatever is causing the pain? Is it the pain that we might find it very difficult for us to treat? So again, what is the impact of on the patient's quality of life? That is very important, because palliative care, pain management, it's all about quality of life of the patient and the family, that we can make them as comfortable, as pain-free as much as we can. So again, taking a detailed pain history is very important, so that we can help us understand how to control pain. Remember, I said pain has got many dimensions to it. It's not just physical. As you're taking history of this pain, find out if there's psychosocial pain, there's emotional pain, spiritual pain, because if you focus only on the physical pain and try to manage it, as much as possible, you might not completely manage it, because you have not addressed the spiritual pain the patient might be having. So you might not have the answer to the spiritual pain, but listening to a patient and talking to a patient is already a way to start addressing their spiritual pain. So we need to look at pain holistically and not just physically. Next slide, please. So management of pain, I thought I should mention that we still are not doing very well, even in public hospitals. It's not only in the humanitarian conditions, situation, or settings, but I think even in the normal settings, we have not done very well because of poor healthcare systems. I know we have a WhatsApp of people working in palliative care. We're always having, a cry that, we have run out of opioids because of stockouts, but that's not the only reason. Our healthcare systems might be poor and weak, but also because of the lack of knowledge of skill of healthcare workers. Most healthcare workers have not been taught in details on how to assess pain and manage pain. And even if they have, some of them are afraid to prescribe certain medications because of the myths and beliefs of those medications, which we'll look at a little bit later on. But also the other challenges could be the patient challenge. Patients also go on the internet, they read things, they hear things from left, right, and center, and they say, I don't want this medication that you have prescribed for me because it's going to make me addicted. So all these things can actually lead to challenges in us treating our patients' pain. Next, please. Next slide, Erin, please. Is it stuck? So I just thought it would be good to mention the non-opioids. Our topic is on opioids, but I think we don't just start with opioids in managing pain. We usually assess the pain, and the pain is mild. It's a mild pain, maybe between 1 to 3. We don't necessarily need to use opioids. We can actually manage this pain with medications that are very common in our setups. For example, paracetamol. The doses, I will send this, Erin will share a PDF of this presentation so you can look at the doses later on, but I'm sure these are familiar doses, that these are drugs that you're very familiar with, and you're very familiar with the dosaging and also the side effects of these drugs. So paracetamol is usually common in most places, ibuprofen also, and diclofenac. The only thing we need to do is to be very aware that these drugs can cause very serious side effects if you use them for a long time, and they can cause GIT bleeding or renal toxicity, and especially in older patients, we have to be very careful how we use these drugs. So don't use them just carelessly. They are drugs that, even though they might not be obvious, they are drugs that we need to use with a lot of caution. We don't use them for a long period of time. So these are the drugs that you might find that are very easily available in our setups. Next slide, please. Erin, next slide. So the opioid analgesics are the ones where we usually have a challenge with the healthcare workers. I just maybe I will try to briefly describe this as much as I can. When you have assessed pain for the patient and you realize the pain is in maybe between 4 and 5 and 6, then you start thinking of moderate pain and you start thinking, I need to use maybe an opioid for this patient. If the pain is beyond 7, mostly we are now talking about maybe a strong opioid. There are certain regulations that we have been given by WHO, the World Health Organization, on pain management that are very basic and very useful and have been validated and researched on, that we can use to manage cancer pain, but also can be used to manage other pains as well, not just cancer pain. So mostly when you're using opioids, we are told that we have to give them as prescribed by the clock, if it's 4 hourly or if it's twice a day, depending on the formula that you're using, whether it's a slow release or so it depends on what you're using. And then we are told that we should give it by the ladder. That is, if the pain is not being treated by what you're giving them, we titrate the medication according to the pain. We change the medication according to the pain. So we go up the ladder from maybe an non-steroidal anti-inflammatory drug to an opioid. And then we are told, as much as possible, we should be able to give our patients their medication by the mouth. That is the preferred route of administration, unless the patient is not able to swallow. And then maybe we might think of subcutaneous or other ways of giving the patient their medication, or even rectal route if possible. So we have to also remember there's something that we call breakthrough pain. That is pain that comes between doses, and we need to be able to manage that pain for the patient as well. And then we hope when you're treating pain, remember that everybody is not the same. Everybody's pain threshold is not the same. People might be having the same illness, the same cancer, but one person might need more pain medication than the other person. Not every size fits everyone. So again, it's not only about opioids and NSAIDs, but also we have other adjuvant therapies that may be needed in controlling pain. But all throughout, we have always remembered the side effects of these medications. We try to prevent side effects, minimize side effects as much as possible, especially if you're using opioids. You'll find that opioids cause constipation. So you need to manage constipation from the first day you're actually administering opioid or prescribing opioid to a patient. So the WHO ladder, the first step is usually talking about a non-opioid, for example, paracetamol, brufen, or diclofenac, plus an adjuvant drug. We'll look at what the adjuvant drugs are later on. And step 2 usually talks about an opioid for mild to moderate pain. If the pain is now getting between 4 to 6, you might now start thinking, oh, I need to move from paracetamol and maybe give them the hydrocodone, DF118, I think is the most common one, or tramadol. And then, of course, plus a non-opioid, plus minus a non-opioid and adjuvant drug. If the pain is going beyond that, and you've given the patient pain, you're reviewing them 12 hours later, 24 hours later, they're still in so much pain, then you need to think of moving up the ladder to the fourth step, to the third step. And the third step is usually where you're giving an opioid and a non-opioid and an adjuvant drug. So again, like I said earlier on, not just the physical pain, think about the other things that could be contributing to this patient's pain, and spiritual, psychosocial, emotional needs. And then, of course, that helps. The fourth block, we'll look at it now in a while. The fourth block is usually now when you go into other, like interventions. That if this is not working, then you might need to do some interventions. For example, now block is one of the interventions that you might need to do at step 4. Next slide, please. And Erin, let me know how many minutes I have left. I think I've done, but I think I have a few slides left. So this, I'm not going to go through this as well. This is just showing us some of the weak opioids. Tramadol, we know it's a common drug that we use in this country. Some people react very negatively to it, so you might not find it being used all the time. We have what you call codeine, or DF118, that is also more common in public hospitals and private hospitals. I do not know. As we do the case study, we'll find out, is it common also where you're working? Then some experts also say, if you don't have codeine, or maybe if the patient is sensitive to codeine, if they have mild to moderate pain, you can actually moderate to severe pain, so you can actually give them low dose morphine. So instead of giving, for example, 10 milligrams, which is usually our starting dose, you can give them maybe 5 milligrams for hourly if you don't have those other drugs. And so you can actually decide whether you're going to use low dose morphine as a step 2 medication. Next slide, please. I didn't put the side effects there because we'll see them in the next slide. Next slide, please, Erin. Next slide. It's a funny.
Hey,
So,
Dr. Zipporah, just about 2 minutes left for this presentation.
Okay, I'll try. Yeah, but I lost some minutes. Okay, so for the third step, we talk about strong opioids, and because of time, I will just mention the strong opioids that we usually use in our country. For example, or in many countries actually, which is more easily available, is the oral morphine solution that we give to patients who have got more moderate severe pain. Some will say the starting dose is 2.5 to 20 milligrams. It depends on the age of the person, on the frailty. If they're frail, if they're elderly, then you might need to start with the lower doses. It really depends on the patient. So it's for us to be able to understand what state the patient is in before we give this medication. Then we also have sustained release, slow release formulation that can be given either 8 to 12 or 8 hourly or 24 hourly. And these sometimes are not easily available because sometimes mostly they're expensive. So the oral morphine is we find is easily available. And you usually start with oral morphine until you have been able to manage the pain, and then before you change to the slow release. Because if you start with slow release, the patient will be having a lot of pain in between. Side effects of these drugs are very common, especially constipation. If you're prescribing an opioid, you must prescribe a laxative, and also something for vomiting, because some of them might feel nausea. Drowsiness usually is something they might have, but it improves after 3 or 4 days. So you need to educate the patient on some of these things. They must be on a laxative throughout. You'll tell them about drowsiness so that they don't worry if they're drowsy. The family members will not worry if the patient is drowsy. So I'll not mention these other strong opioids because they're not really easily available in our country. Oxycodone is available maybe in 1 or 2 private hospitals. Fentanyl patches are very good, but they're also very expensive. Methadone is available in very small amounts. For example, in Kenya, mostly used for drug addiction, for treating drug addiction. Pethidine, which we used to use before, is not allowed anymore. It's actually not used because of the many side effects it has, and also because of the fact that it's easily abused, especially by health workers. So like I've talked about the starting doses of morphine, but also just want to mention that there's a way we can convert one drug to another drug if we're changing a patient from one to another. So this is just a diagram that shows the WHO step ladder, where we have a non-opioid, then weak opioid, then strong opioid, and if it's not working, then going into the fourth step, which is really might involve invasive treatments. Next slide, please. This is for children. Children, we have removed the second step because children are not able to metabolize opioids, weak opioids, and the side effects are more prominent in them. So we actually talk about children. We talk about step 1 and step 2. So a child, you can start with the non-opioids, but if the pain is intense, moderate to severe, then you will actually you are required to start with morphine, and we avoid DF118 or codeine phosphate or tramadol in children. The next slide, please. So remember, for mild pain, we start with a non-opioid with other drugs, maybe adjuvants. For moderate pain, we start with a weak opioid, or codeine or low-dose morphine, and severe pain, we start with a strong opioid. And pharmacokinetics of opioids, the oral opioids take about 15 to 30 minutes to start. The subcutaneous will take a shorter time, and the IV, of course, even a shorter time. So again, the oral of morphine will wear off faster in the system, and so we need to know that it's given every 4 hours because of that reason. So this is just again something that you'll find available in that little book that I've downloaded on the ECHO site. Next, please. So there are myths that morphine kills. Morphine causes respiratory distress, and also many other myths, but morphine does not necessarily kill if used correctly. It does not cause respiratory depression unless really used unless you're giving to an opioid patient for the first time and you're giving heavy doses. In fact, it's used for breathlessness, and even during COVID, it was found to be very useful for those who are having problems. And then the side effects I talked about, the drowsiness, we need to be able to tell our patient that this will wear off after a few days. So again, we need to go above these myths and treat our patient's pain appropriately. Next, please. I think I'm finishing. Okay, I will not go into this, but there are other interventions we can use. Like I said, level 4, we can use blocks or infusion of some of these medications. Then, of course, there are other adjuvants, means that ways that we can also treat pain in terms of TENS machines, acupuncture, massage, and all those things. So, in summary, continuous pain requires continuous therapy. Analgesic drugs should be given regularly. The oral route is the one that we prefer to use, and it's easier to prevent pain than to treat pain. And of course, remember, pain management is not 1 month's job. It's a team effort, and a team effort as a physician, nurse, the physical therapist, the occupational therapist, the spiritual caregiver. All these are very important in managing pain. Our aim is to make sure that the patient is pain-free at rest and at sleep, and most of the time, as much as possible. Next slide, please. I think we are finishing. So I just wanted to finish with this reflection. Marwa is a 28-year-old woman with cancer. She reports a pain score of 5 out of 10. Which medicines would you consider prescribing for her? Just be thinking about this. We maybe come to it later on as we discuss our case studies as well. Put codeine, tramadol, low dose morphine, any of the above. And if you are to prescribe low dose morphine, I was giving this to people in Kiambu. I used in Njeri. I tried to change it tomorrow and I forgot. So what would we give her as a starting dose if we are giving low dose morphine, and what other prescriptions must be taken at the same time? So this is just for us to reflect as we gone through this session. What would we treat this patient with? And next slide. I think I'm done. I think that's so. The next slide is just references, and I'm sorry I rushed through the session, mostly because of the challenges we had, but that's not the reason only. That pain management.
Thank you so much, Dr. Zippy, for the presentation. Do you have any questions? Does anybody want to comment on the case study that was presented and share what they might do or which medicine they might consider prescribing to Marwa? No wrong answers here. We're learning together. So Mohammed said any of the above, okay?
Dr. Zippy, in situations like this, when you only have access to codeine, is codeine a good option with a laxative for someone with 5 out of 10 pain?
If you have access to codeine, it's a good. Actually, any of these that I've listed are good. It's just that I wanted people to realize that we can use any of these ones in pain 5 out of 10. It also depends on what you have available within your setting. Yeah. And if prescribed low dose morphine, you'll probably start at the lower dose because you're using it you're using morphine as a second step of the treatment.
Some good answers
That's
in the
great,
chat.
and I think, yeah, and I think.
Hello.
Oh, hi, Ali.
Thank you. Good afternoon, Sarah and my team. I would like to ask one question to Dr. Zibi. This is an example. You had a patient who is having a drug addiction, drug misuse. In a scenario, maybe that patient comes to you in your consultation area. Patient was having severe pain. You try to give him opioids and some other kind of side painkillers, still no improvement. The history, if you take a proper history, you ask them what is the problem, why this patient is not doing any change. You find out that this patient was having drug addiction. He was addicted to drugs. If you give tramadol or morphine, still no improvement. He was been using drugs too much before he becomes sick. What is the other option we can do, Dr. Zibi?
Actually, that's an important question. I remember we worked on treatment guidelines for people with addiction in this country, and I was invited to sit on the technical working team on that particular document. For the simple, I actually insisted I have to be in that technical working group because I know that people who have addiction problems, usually when they come for pain management, they are told you're an addict and they're not given medication. People are reluctant to give them medication. But we have to remember that even though they're addicts, they have pain. They usually come because of the pain. Of course, there is also the issue that they might misuse the medicine because they're addicted. I think we need to be able to do a very good assessment of their pain, first of all, to understand what pain they're having, to also know what medications they're addicted to, what they're taking, sometimes they're taking things out there that we don't know, that we can't even measure what it is. But also if they're taking any medications that we can find out, we find out what they're taking, and then we actually need to prescribe for them, maybe under observation, close observation than we would for anybody else, and understand how, and we might need to titrate their doses higher than everybody else because of the fact they have addiction. So what I would really suggest that you need to assess that patient properly, find out what it is they're taking, what they've taken before, and then look at what you have that you can give them, but do not deny them pain medication, because even if they're addicts, they don't always have access to those addicted medicines they have. They get them, they take them when they have them. So in between, they will be in pain because they don't have the things they're addicted to. So we need to go, and I will maybe share again on this. I'll share with Erin the guidelines for treating drug. Let me not say drug abuse, for people who use medications. Guidelines for treating them, because we actually put those guidelines on pain management and psychosocial support for people who use drugs. I will send that so that you can share with her. You can have more detailed information about it. But what I really want to say that we should not deny people who use or inject drugs pain medication, because if they come in pain and if they have cancer, they are in pain. So we need to assess that pain and treat it. I don't know if Erin or Sarah from you have more. You probably have more exposure to, because in Canada you have actually homeless hospices for homeless people, and mostly these are people who inject and use drugs. What do you do for them?
So I can comment on that a little bit, because I did spend some time working in a hospice in Canada where we looked after patients who were homeless. Many of them had mental illness and then suffered from drug addictions. One of the things that I think we often make a mistake on is that a lot of these individuals have a higher tolerance for pain medication. They've been using opioids maybe quite regularly, and so their tolerance is much higher than maybe the public, where you'd introduce a very, very small dose. And so I think that a lot of patients end up suffering when we stick to the very strict guidelines of starting with a very, very small dose and then titrating upwards, because their pain is not being met very well, or their pain management is not being managed very well. So I think that's something that that we really have to consider when we're helping to support these patients, that the doses that they require may be higher than the general public, and that it's difficult to accept that sometimes, but that also may be necessary to help alleviate pain. I think one of the biggest things too is stigma associated with drug addiction. There is a lot of pain and suffering individuals are going for. And I think as healthcare providers, creating a space where even though their decisions may not be in line with ours and our values, that they can still express their pain, and that they can still expect compassionate and empathetic care from healthcare providers, and that their pain won't go unaddressed because we feel as though they've brought some of this on themselves, or we place some of our values on them. So I think those are the two biggest things that I took away from that experience, but I'm not sure if anyone else has anything to add.
Yeah, Ali, it would be also interesting to understand the population that you help and support in terms of protracted crises. I know Ali works in Dadaab, where some people have been living for many years and may have struggled with things like addiction or substance use disorder. So it is interesting. I think we could try, Ali, and talk with the team potentially at MSF that has the large mental health program, and see how they help some of those patients. Because I think you're right, Ali, a lot of your population may actually be dealing with this. So we have to have good solutions. Not only would they be dealing with a substance use disorder, they could also be dealing with advanced cancer that has not been treated, the primary cause of the cancer, it's metastatic with advanced disease. So I think it's really good, Ali. Let's keep talking about this. Yeah, Zippy, if you can send me some of those resources when you did work with the strategic team looking at that. I think it's a really interesting topic we haven't really talked about much, but I think as we work with refugees in settings where they are seriously impacted by protracted crises, is something we should talk about and have a way to advise on. So, Sarah, why don't we head over to the case study? Unfortunately, I don't see the team from MSF online, but they may have logged in a different name. I'm not sure if they're sharing a different Zoom account, but let me share my screen and you can introduce the speaker.
Oh, hello. Do we have our speakers here, Erin?
You can see Bull Agoth, are you there? He may be logging in with a different name. I'm not sure. I know they're usually it may not be here, but Sarah, I can also go through it unless my background noise is too loud. I'm not sure if it's distracting. Do you want me to go through the case, Sarah? Is the background noise too loud?
Oh, sorry, Erin. I was cut out there for a minute. Yes, go ahead, Erin.
Okay. Just let me know if the background noise is too much. Sorry, I didn't get home in time I was stuck in change my plans. Anyways, so we've had this case that has been shared by the MSF team in Malakal that provides holistic care to patients in South Sudan. And it's a funded project through MSF Spain. So a clinical officer presented this case. I have a feeling Bull was not able to get connected today, probably due to the network. So let me key questions we'll talk about today. So as you're thinking about the case, I want you to think about, number one, how do we communicate with the family who has no access to curative treatment for their child? The second one is, what could be the next step in the planning and preparation phase to transition a child to home in a humanitarian setting? And number three, what are some of the interventions that would improve the quality of life of this child? So I want to introduce you to this patient. She is a 4-year-old girl. She was diagnosed with leukemia in 2021. And we will be sharing the story about when she was readmitted in 2022, February, due to severe malaria and severe anemia. So she presented with moderate anemia and diagnosed with leukemia in May 21 at a county level facility, yet did not have access to cancer-directed treatment at that time. Symptom management for her fever and pain was managed with paracetamol, as well as nutritional support was given, including folic acid and ferrous sulfate. From the county hospital, they were then referred and traveled to Malakal, but were delayed in their presentation to the hospital, where the patient was assessed and then admitted for further investigation. A clinical exam was performed as well as lab work. So during this time, a telemedicine consult was done, and the CBC FBC hemoglobin was 2.9. Immediate blood transfusion was done, and it remained quite low at 3.8 on a second day post-transfusion. At this point, there was a confirmation in her diagnosis and of ALL, as well as severe malaria. So now as we think about the patient's pain and symptoms, the patient was quite sick looking, emotionally fatigued and withdrawn at times. She was in pain, which was treated with paracetamol, and relief was gained by using these types of analgesics. She was breathless due to the anemia and her blood levels, as well as she was febrile. Notice when the team assessed her that her lymph nodes were swollen, and she also had an enlarged spleen and liver. She was quite dizzy. She had lost a lot of weight and been having some recurrent nosebleeds. We also noticed, tiny red spots on their skin. During the treatment time, after the malaria was treated, the anemia was persistent despite 4 transfusions. Some basic vital signs were taken, as you can see there. Her creatinine was high and her urea was normal. The family explained that in this current situation, we had to focus more on palliative care because treatment for cancer-directed therapy towards her leukemia was not available in this area of the country or in South Sudan as a whole. The treatment plan for symptom management and support was identified to the parents. So we explained this to the parents and mentioned that we were going to take a palliative care approach to care. Treatments such as IV subtriaxone, paracetamol, morphine, and some nutrition therapy was given. And again, the cancer-specific treatment was unavailable. In terms of the psychosocial support, the patient was firstborn, and I had mentioned the patient was 4, and she had a 4-year-old brother. The patient and the family was Christian by faith. The parents used to take her to church to pray. The parents and relatives hoped that God would one day perform a miracle to cure her, though she was in serious, severe pain. Sometimes the grandmother of the child would cry, blaming God that why would God let a young child like this suffer and not take an elderly person like her who had already yielded such fruit? The patient was in the company of both parents, relatives, and the younger brother. The parents were hoping that they could go their desires to in God's hands, knowing that she was in a long pain. did believe in traditions where people who are dying are surrounded by their family members, which
Aaron, are you still there?
can you guys hear me still?
Yes.
And healthcare providers spoke different languages. Communication was done through translators, but there was a feeling for the healthcare providers, they weren't able to obtain the correct information. And the parents seemed quite fearful. So some miscommunication due to language barriers. Privacy was prioritized since there wasn't enough room for visitors and other people to join the family. Spiritually, the patient and family and community have a lot of trust that only God can heal or decide when a person dies. Their biblical concept of death of a sick person, sick person seemed important to the family since they believed it's better to die when they are holy. And due to their specific faith belief, they were convinced that prayers would be enough to heal the child while they were at it. In terms of different collaborations and partnerships that happened, the patient was able to access pharmacy and lab in the facilities, and mental health professionals also were able to provide some support. And the nutrition or dietitians were able to also help. There were some other NGOs that were providing care, such as Tear Fund, MSF, UNHCR, as well as the medical team and doctors. So in summary, this is a 4-year-old girl with untreated leukemia, ALL, who was diagnosed in May 2021. She had severe anemia, severe malaria when she was readmitted in February 2022. She's the firstborn of a family of 2 children and parents. The patient and family and relatives remained positive even when they were informed about the prognosis. Symptom management was done in the facility by the medical team, and they decided to take the child home where the child passed. So now we want to discuss today. You may be reminded about a case very similar.
Erin, we've lost you. Is it me?
No, I think we lost Erin. I'm just sending her a note.
I think we can finish with the rest, the summary.
Yes, okay, so I'll just read this summary of the case. So 4-year-old girl with untreated leukemia, diagnosed in May of 2021 with severe anemia and severe malaria on admission. Firstborn in the family of 2 children and parents. Oh, we lost the slides. Okay, so I'm sure Erin will be rejoining us. We'll just give her a minute to rejoin. Does anybody have any initial comments on the case that they'd like to share? Anything that they want to put in the chat? Any questions that are coming up? Just maybe put all of your questions into the chat and we can answer some of them. If anything in this case is resonated with you, familiar to you.
I think the case was done. It was summary. The case was summary. I think. So
Yeah.
now, let me know. Was there any blood donation blood transfusion for that child who was having anemia of 2.9 in the case.
I think the child was transfused 4 times.
So Aaron has put some questions into the chat. How do we communicate with the families who have no access to curative treatment for their child? What could be the next steps in the planning and preparation phase to transition the child home in humanitarian settings? And what are some of the interventions that would improve the quality of life of this child? Does anybody want to comment on any of those questions or write them into the chat? I think that from what we've heard from a lot of you is that often in some of the settings that you're working in, even though treatment may be something that is there, it's not available for the patients that you're caring for. And so communication might be more difficult. Does anybody have any comments on how they have communicated with families where no treatment exists or is available to the patient? If they want to include it in the chat.
Can we also talk?
Yeah, of course. Please go ahead and talk. Yeah.
I don't like typing. I just think that this is really, really very sad. First of all, I don't have the answers. I'm just saying it's a very sad situation that a child can have leukemia, and sometimes, you know, kids with leukemia can have a good outcome if they access to a proper treatment. But that all we can do is really give, whichever way you're going to give the message to the family of this child, is a hopeless message in many ways, because what they want to hear is our child is going to get well. But we are actually telling them we cannot treat this child, because they do understand we cannot treat this child because of where they come from, where they live, the situation they find themselves in. So it's really, I think it's a very difficult situation, even for healthcare worker. Breaking this kind of news for this family is a toll to the healthcare worker. So I would even start thinking of how do you even support the healthcare worker in this situation? How do you support the family members that this child, okay, the other sibling is 2 years old, too early to understand what's going on. But I saw Elizabeth on this call, on this session, and maybe Pamela, where they have dealt with children a lot of times, maybe they can, help us understand what other ways we can support, particularly the child and the family parents, because I see that also we are talking about what else can we do for this child that would improve their quality of life. I was thinking, even as we are treating the pain and everything, what other interesting things can we do in this child life, like play, if they're able to play, or even just making sure they're with other children. What other things can we do to distract their pain from their physical pain that can, and now in other places we say play therapy, and the MTRH team the other day at the APCA conference gave a session, a fantastic session on, I can't remember what the session, it was called something, child something. These are available, unfortunately, to kids within formal settings, but for people in Sudan and humanitarian conditions, they're not very common. But I guess the people who are working with this child would need to look at what is available within their settings that can help them help this child in terms of pain management. And I know that they had at the end of the day, what would have improved this child would actually have been access to treatment for leukemia. The symptoms you're seeing, the pain, the anemia, all those would have improved if they had access to proper treatment for leukemia. But that is unfortunate. So really, I don't have an answer. I'm just thinking this is a very hopeless situation. And really, it's sad that the message you can give also is still a hopeless message, that you cannot treat your child because of where they're coming from or who they are, unfortunately. Thank you.
I will also add a comment, a short comment. I don't have a large comment. I can see the summary. The child was discharged from the hospital. After 2 days, the child died at home. The child who needs oxygen and who have anemia and leukemia, was not supposed to be discharged from the hospital, was supposed to remain in the hospital until the baby dies. It's better than even the child could die at home. It's better than that the child dies at the hospital level, so that they can get assistance and a lot of monitoring in the hospital. That's my short comment. Thank you.
I appreciate that comment, Ali, and I'd like to actually explore that a little bit further, because I was thinking as we went over this case that one of the things that was done well here was that the family had requested that the child be at home for end of life and for their death, and that was honored in this situation. So I'm curious to know, in these situations, would that not be the best option for the family and for the child to honor those wishes in a situation where there's so little control over the outcome? Is there a way that you can give back control to the family and to the child in some way, whatever that would look like? So I'm curious to know why, or if anyone else thinks that the hospital would be the best choice if that was not the wishes of the family.
Thank you. If
Hello?
I may,
Hello?
can I go?
Yes, go ahead, Pamela. Go ahead. Thank you.
Yeah, if I may comment, when it comes to issues of death, we need also to look into culture. What does their culture say about death? Some people prefer having their dying person right with them at home, where every member of the family surrounds them and watches as it happens. In such cases, maybe you may not have an option but to discharge them, because you cannot have the entire family in the hospital. Another thing is that this is now a case which is passed, but what can happen in the near future? Because we have several gaps when we are looking into people who are suffering, and especially in humanitarian settings. How can we link, collaborate, network, and find ways whereby some compassionate can be provided so that such a child or such conditions can be referred? I see sometimes we get cases from Kakuma once in a while, and then they're referred to Moi Teaching and Referral Hospital. Then at least they get some treatment. Even if somebody dies, we say, okay, something has been done. How best can it be done for future? Because that one now has happened, but I know many cases will resurface of the same. So in as much as we reassure, we counsel the family, we prepare them for this, it's also traumatic to the healthcare provider that you are looking at a situation whereby you can make a difference, but you are not be able to make a difference because you are compromised by the facilities that you have around. So I believe when we apply things like networking and collaborations and finding out if there are organizations which can be able to help, even maybe to help airlift such children to other facilities, at least it can make a difference. Yes, Play Center was an innovation that we came up with at Moi Teaching and Referral Hospital, after realizing that, because actually a cancer treatment at MTRH started with pediatrics, and we realized that children would come to the hospital. Maybe a child comes to the hospital when he is in class 2 and stays there until when he's supposed to be in class 3. Then we said, okay, what can we do to make a difference? Then we talked to some volunteers who are teachers. So if you are teaching class 2 and we have class 2 children, can you come and spend some little time with them? Do we have some books? And then through that, the Indiana University came in and supported. Do you have toys at home which your children are not using, or wherever you are, how can they be put a place where children can access, so that even as they go through their chronic illnesses or terminal illnesses, they have something to distract their mind? Do we have some things like pianos that they can try to play with to distract their mind from concentrating on pain and death and dying? So just such things, that is my contribution towards that.
Thank you so much, Pamela. And
I think let me add also, sorry for the time, I think is to add on that, for example, in our setup, the refugee camps, for example, basic management at the home level is different also in the hostel level. In case of a patient who is in the hostel who are having terminal illness or a critical patient in the hostel, if the patients or their family request for discharge, you ask them, why do you need the discharge? They say, we need to read the Quran or other things spiritual at home level. So we allow them, all the spiritual leaders coming at the hostel level, we give them time, they read their Quranic or other things, a psychological aspect, and the patient and the caretakers with the family also, they agree. Until the patient improves or until the patient dies, the patient will not be discharged from the hospital. Thank you.
Thank you, Ali. And it sounds like you do really good work to ensure that the patients and the families' wishes are being respected and also achieved, which is no easy thing to do in some of these situations. And I really, really appreciate, Pamela and Dr. Zippy, what you were saying about the importance of taking care of the healthcare providers. These situations are not easy for healthcare workers to talk about with families, and they can be extremely emotionally taxing and sometimes traumatic for both sides. And so I think it's really, really important that we learn to take care of ourselves and to talk with our communities when we're having to walk patients and families through these incredibly difficult journeys. And then also the idea of keeping play and art and piano and all of that, because after all, these are children, and all of the things that they love to do, they have to carry this burden of illness, and to invite some joy through play, through piano, like you said, Pamela, or any of these other things, is something that can help alleviate some of that burden and some of that pain. So thank you for that. Does anyone else have anything else to add or say? This is such a wonderful discussion. Okay, so we're coming to the end of our meeting today, and I think if we don't have any other questions, please feel free to ask your questions after the session is over if something comes up for you and you'd like to get some clarification. Otherwise, maybe I'll take this opportunity to just share briefly a little bit about our working groups. So Aaron and I were able to give a presentation with Ali and Annalise at the conference this past week. And Ali led a discussion on morphine availability in some of the in humanitarian settings, and Annalise led a discussion on referral pathways for treatment. So we are thinking about starting 2 working groups in January, and the working groups would be 6 months long. And it would be an opportunity for people within this community to come together to help solve or work towards problem solving these 2 really big topics. So if there's something or there's one of these topics that's of interest to you, maybe think about it, and then I think we'll create a little bit of a sign-up sheet so that you can choose which one you want to be a part of. It's not mandatory or required. It's only if you feel like you want to be a part of one of these communities. And then over the course of 6 months, hopefully this group working on either morphine access and availability or referral pathways for patients, we'll be able to maybe problem solve some of the big barriers to those issues. So if that is of any interest to you, please let us know. And I think we'll find a way for for people to sign up if they want to. So I think, Aaron, if you have anything else to comment, I just discussed some of the working groups. Otherwise, I think we're kind of coming to the end of the session today. If anyone has any other comments or questions, please let me know, or you can always write them in the WhatsApp chat. Thank you so much to our speakers today. Thank you, Dr. Zipporah.
Okay.
And thank you everyone for contributing so much to the conversation. It's so appreciated. Everyone has so much wonderful experience here.
Thank you.
Thank you, everyone. Thank you, everyone. Can I say something? I'm sorry. I'm Bull Daniel from South Sudan. I'm Bull Daniel from South Sudan. I was the one who is supposed to present this case, but I'm very much sorry. I was on duty in the hospital, and as well as time was not enough for me, and also the internet has been disturbing for the last 40 minutes. So this one has really affected me, and I am so sorry if at all you have gone ahead and finished the case discussion. Actually, we had shared this one with Erin. Then I think if at all she has presented, then I think that is all what I was supposed to present. And so I wish next time I will come up and catch up. The rest of my colleagues are busy in the hospital since we work in different departments. So all of them are busy and they are committed. Here in the hospital, a lot of guys went for leave, and the work is now fixed. There are so many patients who are to be seen, and I think that is what has affected our presentation. But we hope for better presentation next time. I am happy with you. Yeah.
Oh, Sarah, may I ask a question to Daniel?
Yes, you can ask.
Please, go ahead.
I felt hopeless and I couldn't even answer because that was a hopeless situation for that kid, as Zipporah said. How did you feel yourself about that kid? If you could not really, if that kid could not access to curative medicine in your care as a health professional, and do you have a supporting team of yourself at your hospital, so that if you meet such a cases, you sit down and also there is a, what we call supporting teams and care of the carers, where some other people could support in such a hopeless cases?
Okay, thank you so much for the question. Actually, to me, myself personally, as LS personnel, I really feel so bad and so shocked about the misery, about this misery case. Actually, I call it misery because it happened and it went in the way that it looked like as if it has not been supported, though the hospital tried as much what it could. And at the end of it all, the case went like that. Actually, in the hospital here, the palliative care, of course, it has been there, but here in the hospital, since we do change the expert come and goes, there was no committee that was formed actually to be running that. It was during my time when I joined the first introduction to palliative care, is when I collided up with some of the doctors, then we try to do something as in offering. So this case was a case that was referred in from another county. So, and this case has been late, and this case has been delayed. So it came to us and we tried to offer all we could. And even this child being sent home, it wasn't our proposal. It was the proposal of the family. And they were like, we need this child to go home. Please help us and give us the offer. That's why we allowed the child to go home. Otherwise, we could prefer the child to die in the hospital. And that's why I think the child went and just died within the period of 2 days home. Maybe they did not take proper care of the child. So to me personally, right now, as I am now in the facility, we are trying to, we are trying to gather ourselves and try to form a team, a palliative care team. Actually, we have everything here, even the guideline we have it here. Since in MSF, we work with guidelines. We have everything that can support this kind of victim. The only problem is that these conditions, they are very rare. They are not so common. So they don't appear they don't appear time to time, but they can take a long time, then they appear. Like this case just appear once, and up to now we have still not received any other palliative care case. Other cases are curable. I think this is the issue as to why this child was not supported. But we hope so. If we receive another one next time, we will actually give proper care, like what I heard from the comment of my colleagues. We can support this patient, yeah, as in we're offering palliative care. So I do feel bad. I do feel bad.
No, Daniel, can I say something? I don't think you should feel bad. I think you did the best that you could for this child. Honestly, I don't think anybody could have done anything else. You don't have access to cancer treatment. This family wanted the child to go out. Of course, I don't think you should blame yourself at all. I think you gave all that you could for this child. Sometimes we're not able to solve everything. We do the much we can. And then I always like to say the rest we leave to God. But you did all that you can. So you supported the family in the way they wanted. And there's no way you were going to provide treatment because you didn't have access to treatment. You did your best. So don't feel bad. You did your best.
Okay, thank you. Yeah.
I think, Danny, when you shared this case, the MSF team had been working on this case for over a month, and I'm so sad you couldn't present it today. But just seeing people even now staying on longer, being really affected by this case, I think we are here for the next year, and you know that we're not going to go anywhere, even if our team in Kenya is no longer, I mean, even if I'm not living in Kenya, we can find ways to connect. I think the biggest thing about this case, I realized that there will be times where you feel like you failed the patient, right? Like you're just saying now, you feel like you're so sorry that you wish you could have done more. In the situation where, you know, since you got the referral and you didn't have access, what are ways that now you've learned about holistic palliative care? Maybe having that family meeting, finding ways to support the family, helping them to identify what they want for their child, and then not making them feel guilty for going home. I think there's many times in healthcare where we say you've gone home against medical advice. I mean, in this situation, you couldn't give anything else. You assessed her pain, you gave her transfusions, you it sounded like you allowed the sibling and the parents to be surrounding the patient when they were at home, but they wanted more family to be around her. And I think in this situation, the fact that I mean, I'm not sure what exactly happened when they left, but I think a big part of parental grief would be if you made them feel bad, saying that they didn't make a good decision, that might be something they live with for the rest of their life. And I think if you, given the situation was so desperate to begin with, if you then find some way to positively encourage them as they go through probably one of the most traumatic situations in their life, they will remember that. They will remember that you said, okay, you know, do this when she, you know, preparing them for when she was going to die. It's not easy work. I am so proud of you and your team and the things that you did. And I think you will learn from this case. There will be times where it's just too emotionally tough. As a healthcare worker, you feel like you have let them down. The whole system let them down. That is actually true. The system let them down. You guys worked hard. The fact that you're still talking about this case means there's something you wanted to learn from it as a team. And I think this guilt that sometimes we as healthcare providers put on ourselves or even parents, we can avoid that. And I think using palliative care gives us the ability to avoid that. You know, we don't make them feel bad that they're leaving. You know, you say, okay, there's a chance that she's not going to respond. She's going to be very sleepy. She might be in pain. Take these medications. She might die very quickly. She's a very sick child. We would prefer that you would help us, you know, manage her even until she dies here, but we know this is really important for you. What can we do to help? What can we do to make this situation that's really bad? Because I think anywhere in the world, you have a child who has cancer, you want to find ways to treat it, right? But thank you so much. I don't know how, I probably don't have the words right now to say, but I'm so proud of you guys. We've been back and forth on so many emails. I've sent messages to the team in South Sudan to try to improve the case for learning. Really, you guys have done amazing. And on behalf of the PallCHASE team, I know that Dr. Catherine Richardson from Geneva, who leads the palliative care for all of MSF now, she's actually, because of this case, and please tell your team, she is planning a trip to see you in person. And she just wants you guys to know the work that you do is so valuable. The fact that you want to learn, that you want to reflect on these cases that are just so difficult ethically, emotionally. I mean, to be honest, spiritually, it really makes you think about what you believe. But Danny and the team in South Sudan, we are really so proud of you. Please keep doing the work you're doing. We are a team, and you know that. We've been trying to support you the last few months and into this year. Every month, let's get together. Let's find ways to talk about these really difficult cases. Of course, we have the WhatsApp, so you can message us throughout the month. But there's other people on the team. I mean, it is difficult. I know, Pamela, you were sharing a comment about referring patients. One of the interesting things about this case is access to care in all of South Sudan is very poor. So I think it's really good to hear people's comments, you know, trying your best to refer. Sarah and I wanted to share with you all that we are hoping to launch some groups that can look more specifically at some of these issues that really tie the hands of the healthcare workers. Referring patients is really difficult in these places. It's next to impossible. So we're hopefully going to be able to bring together some other people and find ways and continuing to work with people like MSF, continuing to advocate for better care for patients in these really desperate situations. But I guess I'll probably stop talking now, but thank you so much. Thank you for all the work that you do. We are so proud of you at PallCHASE. And yeah, sorry, the connection. My connection was also rubbish too, and I'm in Nairobi. I have no excuse. Sorry, guys. But thanks, Sarah. I'll pass it over to you, Sarah, to end. And Sarah, I'll just share I've shared a few photos, but I'll share them on the WhatsApp group with everyone about the workshop from this past week.
Thank you.
Thanks, everyone.
Thank you. Thanks, everyone. Thank you. Thank you. Thank you.
Thank you so much, everyone. Yeah. Thank you for participating.
Bye.
And we'll see you next time.
Thank you. Hi, Caroline. I didn't realize it was you.
Thank you, Sarah. Goodbye.
Like you. Bye.
Bye.